Hi, I'm Brijeshwar Maini, and the title of my talk today is TAVR for Bicuspid Aortic Stenosis. These are my disclosures. So, bicuspid aortic valve certainly is present in up to 2% of the population, and males certainly have more bicuspid aortic stenosis than females do. And in retrospective examination of surgically excised valves, it appears that 20% of patients have underlying bicuspid pathology. Now, what is this characterized by? It is characterized by a larger annulus perimeter. There's an asymmetrical valve orifice and a heavily calcified leaflet, raphe, and LVOT, and what is normally described as a stovetop aortic root, which is from time to time difficult to evaluate and to treat. So if you look at this pictorial depiction of the tri-leaflet valve on the left side and the way it opens versus a bicuspid valve, and you can see a slit which is horizontal and the way it's opening. Similarly, you can see a CT scan of a bicuspid aortic valve, and you can see how calcified the leaflets are, and certainly an excised aortic valve is seen here. If we were to look at it on an aortic root angiogram, you can see the bicuspid aortic valve. You can see the calcification, which is at the leaflet tips. Interestingly enough, this bicuspid valve is not as calcified as a lot of other bicuspid valves are, but nonetheless, you can see a difference between what would normally have been a tricuspid valve to this bicuspid aortic valve. Now, what is the classification of bicuspid aortic valves? And the much talked about Sievers classification. You can see Sievers type 0, in which there is basically presence of two cusps. Sievers type 1, which is the predominant type of bicuspid aortic valve, in which one of the raphes is fused. And then Sievers type 2, which occurs in 3.5%. There's two raphe which are fused. And as is depicted here, Sievers type 0 is present in 14% of patients with bicuspid aortic pathology. If we were to look at the phenotypic classification of bicuspid aortic valve and aortic root, it is pretty explanatory that if you look at type 1, you could have an AP orientation, you could have a right and left orientation, and these numbers vary. 79% of them are, as you can see on the right side, are AP, whether the raphe is fused or not, and the right and left are present in 19% of patients. This is important for us to understand because a lot of times the way you will be planning your therapy with a percutaneous aortic valve replacement would depend on the size of the sinuses, the way the leaflets are oriented, where are the coronaries coming from, what is the size of the sinuses, what is the issue with closure of coronaries as the leaflets stand up as you implant a percutaneous heart valve. Moving on, I think it is very important for us to understand that bicuspid aortic pathology does not come by itself and is usually associated with a lot of other comorbid conditions, including coarctation of the aorta, which is present in 50% of this population, Turner syndrome, supravalvular AS, subvalvular AS, PDA, VSD, Schoen complex, ascending aortic dilatation, which is common. And I think this is a very important associated condition that we have to pay a lot of attention to, especially in younger patients as we embark on lower risk patients and doing percutaneous aortic valve replacement in these patients and the associated ascending aortic dilatation. And as you see in this slide, if you look at the International Registry of Aortic Dissection, bicuspid aortic valve was certainly a very important pathology that was associated in this patient population. So something very important to keep at the back of our mind if we see a young patient with bicuspid aortic pathology we really have to take into account the aortic dilatation. What do we think this patient is going to have a risk of an aortic rupture, an aortic dissection? And would this patient be better to get a open repair with probably an ascending aortic replacement at the same time versus getting a TAVR? So moving on, if we look at the bicuspid aortic valve, there are certainly multiple unfavorable anatomical features, including the annulus is more elliptical. So it would be like putting in a round peg in a square hole, if you will. There is asymmetric heavy calcification, and there is bulky calcification extending into the LVOT, which is a big problem. As we all know, that is a very big concern, especially when it comes to paravalvular leaks and certainly for annular rupture as well. Coronary heights are lower, and hence the concern of coronary obstruction is certainly something to be kept at the back of your mind. Sinuses are certainly smaller in general. The sinuses are effaced, and a concern. We already spoke about ascending aortic dilatation, and also, not to be belittled, the highly angulated annulus, which would make percutaneous aortic valve replacement more challenging. So if we were to look at procedural challenges, what procedural challenges might we face when we are doing percutaneous aortic valve replacement in patients with bicuspid aortic stenosis? So the concerns that might come might include a valve misplacement, and we'll go over that as to the shape and size, the contour of the bicuspid pathology. Where exactly are you going to place your percutaneous heart valve can change. So you could certainly misplace the valve. Asymmetric valve expansion is certainly a concern. High residual gradients are known to happen and something that we need to understand and know about. Paravalvular regurgitation is certainly a big concern, and especially when we start talking about lower risk patients. So moving on, TAVR in bicuspid aortic valves may be subjected to an increased risk of complications related to irregular and incomplete expansion of the prosthesis, and as I was just mentioning, is putting in a round peg in a square hole. And if you were to look at the rendition on the left side, where you have a tricuspid aortic valve and you have a circular aortic prosthesis, it's going to sit a lot more nicely, versus you have a bicuspid aortic valve, and as you can see, there is presence of two leaflets, and expansion of these leaflets, which are going to be very calcified, is not going to happen in a symmetrical fashion, thereby leading to all the issues that we were just alluding to, including paravalvular leaks, increased mean gradients and such. So if you look at the existing data with first generation valves, we know that there may be a higher risk of having moderate or severe PVL to the tune of 25% compared to tricuspid valves, which is lower, to the tune of 15%. We were just alluding to the thought process of not being able to expand a percutaneous heart valve in a bicuspid valve. And as you can see here in the picture, if you have a tricuspid valve, the percutaneous valve is nicely expanded, it's circular, versus you have a bicuspid aortic valve, Sever's type 0, if you will. The circularity, if you will, of the percutaneous heart valve is not as good as what you would see in a tricuspid aortic valve. So if you look at the multivariate analysis that was done in the BEAT International Collaborative Registry, what were the two things that popped up, if you will? The first one was BMI. BMI certainly led to an increased residual mean gradient. which it's easier to understand. Okay, that very well is understood. But one of the things that really stands out amongst other things is the presence of a type 0 bicuspid aortic valve. Apart from that, the ascending aortic major dimension, the annular area, perimeter, all those things, pre-dilatation, post-dilatation, the percutaneous heart valve type and size, including, surprisingly, the aortic valve calcification, did not have much of a bearing on increasing the mean gradients within these two patient populations of tricuspid aortic valve versus bicuspid aortic valve. Let's go on to some of the newer data. This is a publication that was just accepted for publication by Ron Waxman and his group, and this is a prospective bicuspid TAVR cohort. And it is interesting to point out that a total of 360 patients were evaluated, and a total of 61 patients were enrolled in this prospective study. And only 16 patients received a self-expanding percutaneous heart valve, which is important to note, and therefore we cannot make any distinctions between balloon expandable versus self-expanding valve, which we all want to know which one of these valves is going to do better in the bicuspid aortic valve pathology. Interestingly, these were the conclusions from this prospective study, and as per the authors, it appears that TAVR is safe in bicuspid aortic stenosis patients. The hospital's length of stay was short, there was no mortality, there were no strokes. The subclinical leaflet thrombosis was observed in a minority of patients and did not appear to be any different than other cohorts, which is actually good, because one of the concerns that we as operators have is that if the valve is not going to be opening symmetrically, and it's going to be more constrained, and the leaflets are not going to have as good of an excursion, would there be more of a leaflet thrombosis, which thankfully was not the case. So this is good news for TAVR in bicuspid aortic stenosis. Moving on with yet another very new publication from the TVT registry. Again, good news. There was no difference in in-hospital death. There was no difference in in-hospital stroke. Also, there was no in-hospital WARC differences in bleeding, which is very, very good. Interestingly, also, what they found in the TVT registry was that the device success was similar, whether the patient had a tricuspid or a bicuspid valve. There was no difference in conversion to open heart surgery. There was no difference in the need for a second valve, i.e., there was a concern, as we were alluding to, about placement of the percutaneous heart valve. There obviously was no need for more valves to be implanted in patients with bicuspid aortic valve. The post-TAVR mean gradient was not much different, and certainly not statistically different. And the post-TAVR aortic valve area was also similar. Again, very, very good outcomes in the real world, which is very comforting to know. Now, we've always said people with bicuspid aortic stenosis are certainly going to have more of a problem with paravalvular leak, and based on the TVT registry, yet again, it does not appear to be the case. Certainly, there was no paravalvular leak in 70-odd% of patients. Severe paravalvular leak only occurred in a very small minority of patients. Certainly, there was more mild paravalvular leak, but again, no difference between the two groups. Again, is there room for improvement for paravalvular leak, not only for bicuspid but for tricuspid valves? Absolutely, yes. And as newer generation valves come to being, this certainly will be a problem that I'm sure will be addressed and be taken care of. So moving on, again, people feel that self-expanding valves may not fare as well as balloon expandable valves. So this is the study from the core valve family of trials, And in this, what they found was that bicuspid patients with severe AS were successfully treated off-label with 3 generations of self-expanding valves. And as the self-expanding valve generation changed to the newest generation, i.e. the Evolut R Pros, I'm assuming the degree of PVL and all those things have improved. What exact difference is there going to be between self-expanding and balloon expandable? Obviously, we need a lot more data. The concern always will be is that self-expanding will have more paravalvular leak. Balloon expandable will probably have a slightly higher incidence of annular rupture, if you will, which is understandable. So again, looking at the anatomy, and we'll go over that very briefly as to how do we think we can decide with the data that's available as to what do we think, what kind of a valve would potentially benefit more so patients who have bicuspid pathology. So if we go over and look at the response study, which is now very interesting, if you look at the valve size that was implanted, there was no difference between the bicuspid and the tricuspid cohort. Now, what is interesting is that in the bicuspid valves, the valve was undersized more so than if you had a tricuspid valve. I think which is very important to note. That is a function of the pathology of the bicuspid aortic stenosis compared to tricuspid aortic stenosis, and something that we have to really measure appropriately and decide on the size of the valve as we're implanting it. Moving forward with the registry, certainly there was a significant improvement in the mean gradients, in the mean effective orifice areas, in both the bicuspid and tricuspid aortic pathologies. And the good thing is that they both continue to be good as far as the mean aortic valve gradient and the mean effective orifice areas at discharge and at 1 year. So let's talk about paravalvular leaks. Again, there was no difference between bicuspid and tricuspid with the valve, and which is very comforting that this valve performed very nicely in both tricuspid and bicuspid pathologies. We're always concerned about all-cause mortality, certainly cardiovascular mortality, and need for permanent pacemakers, and so on and so forth. But interestingly, none of these panned out to be the case. So whether a patient had a bicuspid valve or a tricuspid valve, including the VARC safety outcomes, there was no difference. This is a new concept that we need to start understanding, is that annulus-based sizing for TAVR is usable in 88% of the cases, and prosthesis under expansion is a constant finding. Now, there is something known as a mean ellipticity index, which is something that we all have to understand, especially when it comes to bicuspid valve, and I'll tell you why that is important in the next slide. So if you look at how the aortic annulus and something which is called ICD, or intercommissural distance, which is the distance from one commissure to the other, as you can see in the picture here, based on the shape of the bicuspid valve, where the aortic annulus is and where the intercommissural dimension is. If it's in the shape of a tube, then sizing is based on the annulus. If it's in the shape of a flare, then sizing is based on the annulus again, as you can see. You certainly don't want to size it to the intercommissural dimension, especially with a balloon expandable valve, because certainly you'll be looking at some potential complications. If you have the bicuspid pathology in the shape of a taper, where the annulus is wider than the intercommissural then the sizing is based on the intercommissural dimension. So based on what the pathology is, based on what the shape of the LV, the aortic annulus, and the intercommercial dimension is, and as I said, it's 4 millimeters apart, is you will decide where exactly to land the percutaneous heart valve. And looking at it ever so slightly differently, this is how you would do that. Traditionally, how we have done annular sizing, and in the situation of a flare shape, you would do supraannular sizing, which would exactly be as what's shown here. And you can certainly do balloon sizing in bicuspid valves, and you can see the balloon is inflated, and certainly would be helpful for sizing purposes. If you were to look at differences, the way a valve would sit in a bicuspid valve between 3 different types of valves which are commercially available to us thus far. So if you look at the SAPIEN 3 valve, so you have pre-op CT and then you have post-op CT, and you got a nice circular SAPIEN percutaneous heart valve which is sitting nicely. How about an Evolut R, a 29 millimeter, again sitting rather nicely, and so is the Lotus valve. Now, you might say that the Lotus valve appears to be a tad smaller, but certainly these are different patients with different CAT scans, so you can't certainly look at it, even though there may be some suggestion that the effective orifice area of the Lotus valve may wind up being the smallest, if you will. But again, we need to do a lot more research into that before we can comment on it. Predominantly because of the intraannularity of the valve, so the same would happen for SAPIEN. Obviously, core valve being a supraannular valve, the effective orifice areas would be higher, as we know of. I wanted to go over and bring up what I think is ever so slightly controversial. I don't necessarily believe in what this slide says. I borrowed this slide from Mike Mack. And certainly this is, as you can see, is the letter from the FDA approving low-risk TAVR for SAPIEN 3 valve. And again, as long as you have a heart team and you have a surgeon and appropriate transcatheter team available, you can perform these studies. And safety and effectiveness have not been established for patients with the following characteristic comorbidities, i.e., these would be the conditions in which TAVR would not be on label, which would include non-calcified aortic annulus, severe ventricular dysfunction with ejection fraction less than 20%, congenital unicuspid aortic valve, congenital bicuspid aortic valve at low surgical risk. Again, mind you, I want you to point to that word congenital. Pre-existing prosthetic ring in any position, severe mitoannular calcification. Now, therefore, TAVR for bicuspid aortic stenosis is not off-label. I would respectfully disagree at this point in time. I think it is still off-label in my point of view, especially when you're talking about a severe type 0, and we have to exercise caution when we are treating these people, especially the low-risk patients. We have to be very careful with them. For all the other comorbid conditions that we were talking about, I think it's very important. So, is one preferable for bicuspid aortic stenosis? I don't think so as of right now. One may be better versus the other depending on the pathology that we were talking about, whether it's a tube style, whether it is funnel shaped, whether it is reverse funnel shaped or flare shaped, or however you want to call it. This might change depending on the severity of calcification and the size of the native annulus or the intercommercial dimension. We may choose to use one percutaneous heart valve versus the other. Now, these are slides courtesy of Cameron Dowling, and I think this is extremely intriguing as to how would we be able to custom tailor our, because currently available percutaneous heart valves to bicuspid aortic disease, and certainly with the use of CT technology, and by being able to simulate implanting a valve, a size of a valve, where exactly are we going to implant it, it would be beneficial. So again, get a nice CT scan. And again, as you can see here, based on the shape and the size of the aortic annulus, and what have you, you can choose as to what size valve are you going to put in, how deep are you going to put it in, or how high are you going to put it in. I think those things could be customized to each individual patient in the years to come. Now, this technology, as per the presentation that was given by Dr. Darling, is only available for the self-expanding prosthesis. They apparently cannot do it for the sapien valve. Maybe they're doing it now that I'm not aware of. But as this computer simulation with actual valves becomes more available, I think we will be able to implant our valves in a much better, nicer fashion and choose our percutaneous heart valve based on the CT sizes and dimensions and so on and so forth. And again, in this case, you can see one of them, it was chosen to have a deep implant, and in that patient they had a prophylactic permanent pacemaker inserted prior to TAVR in patient number 7. Obviously so, because we know there would be a higher incidence of a complete heart block in this patient, and as expected, this patient did go into complete heart block. So certainly this could be, in the years to come, become a good imaging tool for us to plan which valve are we going to put in, where are we going to implant it, and so on and so forth. Certainly post-procedure cardiac CT scanning would be very important, especially in patients where we have some concern, there is evidence of paravalvular leak, and so on and so forth, and how is the valve sitting. Obviously the concern of radiating these patients again and again would certainly remain, but nonetheless, at least from an academic perspective, this would certainly allow us to evaluate these percutaneous heart valves in a nice fashion. So who with bicuspid aortic stenosis will still get SAVR versus TAVR? Very young patients, I think. I agree, because of, especially with the associated conditions, I think surgery would still trump TAVR in that patient population. Obviously, if the patient has significant aortopathy, you have very hostile LVOT calcium, certainly not a place where you want to put a percutaneous heart valve in young patients, especially. You have low coronary arteries, you have anomalous coronary arteries. I think this is something that we have to become more savvy with, looking at our preoperative CAT scans and finding out who do we think is more likely to have coronary occlusion, how do we prevent it. Do we go down the route of basilica, or do we go down the path of doing surgery? Again, never forget, surgery is still a very good operation. Surgical aortic valve replacement still is and can be performed very, very nicely, expeditiously, safely, with excellent outcomes. And certainly unicuspid valves, in my mind, should certainly get surgery. So TAVR for bicuspid aortic stenosis, in summary, is approved for bicuspid aortic stenosis without randomized data, predominantly for patients with severe type 1 and type 2. In the elderly patients, in the high risk, extremely high risk patients, certainly, depending on how you read the FDA approval letter, certainly could be done, can be done, is done. There's a decent amount of experience with TAVR in bicuspid aortic stenosis, and we do have an idea as to who will do well and who won't, and we can triage our patients appropriately. Some patients will clearly need surgery, especially the younger patients, and any randomized controlled trial is likely not going to happen in my mind. There are going to be more registries, if you will. Would like to have a randomized controlled trial, especially for long-term outcomes in patients, especially the younger patients, for us to understand. But again, as the amount of literature and data continues to grow with our experience with bicuspid aortic stenosis, as the TAVR devices become better and better, probably the need for a randomized controlled trial may not be there. Thank you very much.